Hello, my name is Tracy, and I am a Trauma and Surgical Critical Care Fellow at Emory University. Thank you for allowing me to present this research entitled Identifying Risk Factors and the Optimal Management for Post-Transplantation Diverticulitis. I have no disclosures. Diverticulitis accounts for more than 2.7 million outpatient medical visits and 200,000 inpatient hospitalizations each year in the United States. Among individuals who require inpatient treatment, approximately 10 to 20% will require emergent surgery. This rate is even higher in patients with a history of solid organ transplantation. Rates of mortality from diverticulitis are also reportedly higher in the solid organ transplantation group compared to the average population. This mortality difference has garnered considerable attention from the transplant community. In attempts to forfend these negative outcomes, some clinicians have offered colectomy to transplant patients following a single episode of uncomplicated diverticulitis. Other surgeons offer prophylactic sigmoid colectomy to solid organ transplantation patients with a known history of diverticulosis. We sought to examine institutional risk factors and outcomes for solid organ transplant patients with acute diverticulitis. We hypothesized that pre-transplant diverticulitis would be associated with post-transplant diverticulitis, and among affected patients, there would be no difference in complications or mortality if patients were managed medically or surgically. We performed a retrospective review of solid organ transplantation patients at our tertiary care center between 2000 and 2018. We excluded patients without documentation of diverticulosis or diverticulitis in their medical record. Data was collected on patient demographics, comorbidities, and body mass index. Transplantation information was also abstracted, including the date of most recent transplant, organs transplanted, and any immunosuppressants taken. The cohort was then stratified into two groups, PTD or no PTD. Any variable that was significantly different between groups was entered into a univariable logistic regression to assess for association with PTD. If there was a relationship, this variable was then entered into a multivariable logistic regression to identify independent risk factors for PTD. A secondary analysis was then performed for patients who developed PTD by comparing individuals who were medically treated through antibiotic therapy with or without percutaneous drainage to patients who were treated surgically with a Hartmann's procedure. A primary outcome was the occurrence of any complication, shown below. Secondary outcomes included in-hospital mortality and readmission for diverticulitis-related issues. There were 518 solid organ transplant patients comprising our cohort. PTD occurred in 7.7% of patients and most often 4.5 years after the most recent transplantation. PTD patients were younger and had a greater incidence of pre-transplant episodes of diverticulitis. A larger proportion of PTD patients received azathioprine and prednisone, while a smaller proportion of PTD patients underwent liver transplantation. The results of our univariable regression are shown in column 2 of this table. Azathioprine use, a history of pre-transplant diverticulitis, and prednisone use were associated with the development of post-transplant diverticulitis. However, on multivariable logistic regression shown in the next column, only liver transplantation and age remain significantly associated. Specifically, increasing age and a liver transplant decrease the odds of PTD. Among the 40 patients who developed PTD, 75% were managed medically and 25% were managed surgically. Patients who underwent operative intervention had significantly higher median Hinchey scores, 3 versus 1. There was no difference in rates of complications, in-hospital mortality, or hospital readmissions between groups. We observed a PTD incidence of 7.7% in our solid organ transplantation patients, comparable to previous literature. We also identified several clinical trends connected to PTD development, including a greater use of azathioprine and prednisone. These corticosteroids and antiproliferative agents are used to prevent allograft rejection and have been implicated in the development of infections because of their inhibitory effects on the inflammatory response. Physiologically, these two medications could impair biochemical pathways that would normally signal pericolic fat or omentum to wall off peridiverticular perforations. We also found that a greater proportion of patients with PTD had a history of pre-transplant diverticulitis. Nevertheless, only age and liver transplantation were significantly associated with PTD on multivariable logistic regression. We specifically identified that increasing age correlated with the lower odds of PTD, which challenges the notion that diverticulitis is a disease of older age. Interestingly, a national analysis of 2 million patients with diverticulitis showed that rates of hospitalizations increased annually by 5.6% for patients aged 18 to 29 years and 2.7% for patients aged 30 to 39 years, but decreased for all patients aged more than 60 years. It is possible that our results actually reflect current age-related epidemiologic trends of diverticular disease in the United States. The odds of post-transplantation diverticulitis development was also lower among liver transplantation, which is relatively novel. It should be mentioned, though, that the proportion of patients receiving azathioprine, mycophenolate mofetil, and prednisone was significantly lower in liver transplant patients in the study. Perhaps because the immune function was not impaired by medications, liver transplant patients were better able to mount an inflammatory response and prevent progression to diverticulitis. In patients who did develop post-transplantation diverticulitis, we found no significant difference in outcomes between patients managed surgically or medically. Specifically, we noted a 53% overall complication rate among our 40 PTT patients, which is less than the 57% overall complication rate cited by Lee and Associates in their review of elective colectomies for transplant patients with diverticulitis. Also, all patients surgically treated in our study had Hinchy scores greater than 3, which is a score consistently linked to more emergency operations and independently predicts worse outcomes. Thus, despite being predisposed to worse outcomes, our surgical patients fared the same as the patients in Lee's study. This salient finding questions the role of prophylactic or elective colectomy for diverticular disease in solid organ transplantation patients. Our study has limits, the research was retrospective, and the data came from one institution. We were unable to discern the duration of immunotherapy or actual compliance with medicines. Furthermore, some patients may not have returned to our institution for diverticulitis treatment and would not be captured by our institutional registry. Moving forward, we recommend that patients who develop diverticulitis after a solid organ transplant should be treated using the same guidelines that direct care of diverticulitis among non-transplant individuals. Thank you.